let's get started. Welcome back to the C2 Smart Center webinar series. Today, we're happy to be joined by Sanmay Shelat from Delft University of Technology in the Netherlands. He's conducted research that's especially interesting to C2 Smart in the wake of our own interactive COVID-19 data dashboard, which C2 Smart researchers have put quite a lot of time into. I'm going to turn it over to Professor Joseph Chow, Deputy Director of the C2 Smart Center. But first, a few quick administrative notes. This webinar is going to be recorded and uploaded to the C2 Smart Center YouTube channel. And second, I just want to encourage everyone to ask questions and make comments throughout. It's a much more dynamic presentation this way. So Professor Chow, why don't you go ahead?
Yeah, thanks. Thank you, John. I'm delighted to have Sanmay here to give a talk today. Sanmay reached out to me earlier in the month. He's been staying in New York City, and we wanted to have an opportunity to collaborate a little bit. Sanmay's advisor at TU Delft is Odette Katz, and we've done some collaborations before. So this was a good opportunity to just hear from him and see what kind of work he's been doing. And hopefully we can rouse some interest from the audience and get some discussions going afterwards. Okay, Sanmay, the floor is all yours. I know you plan on having maybe like an intermission somewhere in the middle. So you can just let us know when you want to.
Yeah.
Fine,
yeah.
Go ahead.
Thanks for the introduction. So I'll also introduce myself a little bit. Like I said, I'm a PhD candidate at TU Delft with Odette Katz, Niels, and Hans van Lent. And I study route choice behavior and uncertainty in public transport networks. I'm a part of the Smart Public Transport Lab and the Data Analytics and Traffic Simulation Lab at the Transport and Planning Department of the university. You can see the logos on the left. And my doctoral research is basically a lot of behavioral analysis using stated choice and passively collected smart card data. I'm in the final year and I'm wrapping up my article-based thesis. So the thesis will be a collection of scientific articles, and I hope to submit by the end of this year. I also work on modeling and user behavior of active modes, particularly the bicycle and transit combination, which is catching a lot of attention in the Netherlands right now, and also in other parts of the world. On a related note, my MSc dissertation was also on an active mode, that is pedestrians, where I worked with Philips Lighting. Also, just a quick introduction to the Transport and Planning Department at TU Delft. We do a large variety of, we focus on a large variety of transportation topics, and so much so that we had to divide our work into 10 labs. For example, we have active modes, we have rail, we have freight, traffic. Of these, I'm part of the Smart Public Transport and Data Analytics and Traffic Simulation labs. The Smart Public Transport Lab focuses on conventional transit, on-demand services, mobility as a service, and does user and system analysis, for example, behavior models or optimization of network designs. The DAT Lab, which is the Data Analytics and Traffic Simulation Lab, focuses primarily on traffic flow analysis, but also on freight and public transport, which is what I do. What they do in this lab is collect big and large data sets and apply an array of machine learning approaches and smart card data analysis. So COVID-19 and public transport, I think we have all, although it's already been a year and a half, we remember the headlines, we remember how it was, but already for public transport, right in the first week, second week, you can see the date here, it's March 22nd, 2020. Predictions were being made that the coronavirus has raised US transit and rail systems. It's not going to be business as usual. This is going to go on forever, and it's going to bring years of pain to transit. We have experts saying that this is going to take a while to come back from. Also in the Netherlands, where they report that the crowding on public transport was much less in the March of 2020. Then we had predictions one way and the other. Some people said, "Oh, subways are the prime suspect for the spread of coronavirus in New York City." And then, so you had a lot of information and misinformation flying around, and then you had said, "Well, you say this, but it's not as simple as that." But in essence, the idea is that there were a lot of this has been a drastic. This has had a drastic impact on public transport, and when everybody asks you, including all authorities, ask you to avoid public transport, there's bound to be repercussions on long-term behavior as well. So let's take a look at the overview of the impacts of COVID-19 from a transportation perspective. So let's say we have the four-step model with trip generation, we have travel demand reduction. This happens due to a few activities, which is because of the fear of contracting the virus. Destinations changed. Working from home became the norm. More round trips, less trips to entertainment venues. Cinemas were closed. Restaurants were also closed at a point. Departure times changed. I think a lot of papers have already remarked on the suppression of the morning and evening peaks and a higher midday peak. Modal shift, again, we have a lot of studies on the large-scale shift to automobiles and bicycles, shared scooters, and so on. And this is primarily due to explicit advisories and even shutdown of transit systems and people's own fear of contracting the virus on board. And finally, we have the assignment stage of the step of the four-step model, which is behavior within a system, so within the transit system. And here you have the behavior that takes a role here is how risk factors contribute to risk perceptions and how these risk perceptions are traded off with other travel attributes such as travel cost and travel time. And then you also have some long-term impacts of COVID-19. For example, land use change. As remote working increases, we saw a lot of people rush to buy houses outside the city to stop renting. And this, again, in turn led to an increase in prices. And this could also potentially have an impact on how we design services and networks. So it might be the case that we have to adapt to the circumstances, increase frequencies to reduce crowding, provide new connections because of the change in which destinations people want to go to now. So coming out of this overview, what we will focus on in this presentation is the last part of the four-step model, the behavior within transit, with an aim to analyze how travelers are evaluating the COVID-19 risk on public transport and how various COVID-19 risk-related factors are being traded off. For this, we did 2 stated choice experiments with trained travelers in the Netherlands. We did this at various times. The first one was a simple route choice experiment, but what we did was we included 3 critical COVID-19 transmission-related factors. And the second was about 6 months later, a hierarchical information integration experiment, where we explicitly captured the impact of various factors on risk perception. But I'll give you more details on that. So this is what Joseph was talking about. So I'll have an intermission between these two studies if you have questions. And of course, if you all can see a Q&A tab or a chat tab, please put in your questions there. So just an overview of when we collected the data for the 2 surveys, and what I've done is overlaid it with the situation in the Netherlands. So the blue line that you can see scrolling is number of the number of estimated infectious persons. So what this means is the Dutch government, since summer last year, started releasing numbers on what is the estimated number of people that are currently infectious. So they have COVID and can give it to someone else. As you can see, there is a peak. The first peak was at the end of March, and we collected the data for the first study as this first peak was, as this first wave was ending, and new restrictions were being set up for public transport. So public transport was again, as it was the end of the intelligent lockdown, the so-called intelligent lockdown, public transport was once again open to all people, but with new restrictions such as mask mandates, mandatory seat blocking, and a few other restrictions, but they were all infrastructure. For example, they now had entries from the rear doors or plexiglass to protect the drivers. And then the data for the second survey was collected, and in the first week of December, which was just before a full lockdown. As you can see, it's a surge within the second wave. So this was just before the full lockdown, and the full lockdown after the data was collected also included sorry, I don't find the word, but curfew, an evening curfew, where people were not allowed to go out after I think it was 10 p.m. Of course, these times changed over the, so it was 10 and then 11 and then came back to 9 according to how the infection levels were going. But so basically the point is there were two data collections, about 6 months between them. We had 2 infection waves in this period. The first data was collected, first set of data was collected at the end of the first wave. The second was at the while the second peak was going on. And also we had 3 levels of lockdown between the data collection periods. So we had just social distancing at the very beginning of the coronavirus, of the pandemic in the Netherlands. Then we had a very strict intelligent lockdown where people were not allowed to visit each other, restaurants were closed, and no events were possible. And a moderate lockdown had a subset of these restrictions, but this was just before the full lockdown. But the full lockdown was not considered in the study as all the data was collected before that. So here's the first study where we look at how a COVID-19 related risk criteria affect route choice behavior. We did this, I did this with Oded Katz and Sander van Kranenburg, who's from the Transport Policy and Management faculty of TU Delft. So like I mentioned previously, as you have COVID-19, as the risk of COVID-19 was ongoing in May of 2020, travelers were much more likely to focus on contributing factors. So if you had travel cost and time as the major factors, COVID-19 related factors were probably the next most important ones. And so we focused on 3 most important criteria. One is related to transmission of COVID-19. The first is distance to other people. How long are you exposed to other people? And what is the prevalent infection rate in the society? All of these directly and objectively contribute to the risk perception. Objectively contribute to the risk of contracting COVID-19. So there is no subjective perceptions here. How far you are and how long you're exposed to someone, and what is the probability that someone near you has COVID-19, all objective risk factors of COVID-19. And yeah, in terms of public transport, of course, distance to other people here means onboard crowding, and the duration of exposure translates to in-vehicle travel time. We collected data through an online panel, about 500 respondents, and we sought out people who had used the train at least once a month in the period of May 20 to 25, So like I said, this was just before, so just after the restrictions had been relaxed, but or there were announcements that the restrictions would be relaxed, and there were also announcements that public transport would be reopened with mask mandates and seat blocking. Eventually, in July, they did remove the seat blocking, but this was not captured in the data collection. The collected sample was generally representative of the Dutch population in terms of age, gender, education. And in addition to the choice experiment, we collected a lot of social demographic and mobility characteristics, as well as COVID-19 related factors. For example, how worried are you about the pandemic in general? How worried are you about infecting someone at your home? And how worried are you about getting hospitalized? So let's take a look at the choice experiment. So this was how the choice experiment looked. You had basically two train options where the onboard crowding was shown graphically. So for both, and you had waiting times. So the train options varied with onboard crowding and waiting times. And then you had context attributes, infection rate, and travel time. And you also had the context of your trip purpose. So we decided the situation context as the respondent's most frequent trip purpose before the pandemic. Like I said, alternative attributes were onboard crowding and waiting time. And we did not use travel costs on purpose to avoid income effects and to prevent protest answers. So to prevent people from saying, "Oh, I'm not going to pay for this." We did use travel costs in the next study, and maybe a bit of this effect can be seen. Of course, we are not able to differentiate whether this is a protest answer or if this is what really people want to do. But there might be an intuition that people say, okay, the government is supposed to protect me from the virus. I'm not going to pay more to sit in first class for my safety. I want to sit in the regular class and be safe all the same. So, but that's why we did not use travel costs directly in this first experiment. And we also noted that social distancing was possible. Rating this whole experiment was on board. So this whole experiment is, okay, what happens when you're on board? So we wanted people to know what happens at the platform. Then again, like I said, we had context attributes, infection rates, and in-vehicle time, which was exposure duration. And finally, we noted that masks were mandatory on board. Then we observed rank choices. The purpose of doing rank choices is that we wanted to include the context. We wanted to include an opt-out option because given the context, it seems necessary and it's quite likely that a lot of people might not want to travel by train at all. But we still wanted to estimate trade-offs. So we said, okay, why don't we just observe rankings? And in case a lot of people do opt out, we still have the ranking between train 1 and train 2. And even with lower confidence, we can still estimate some kind of trade-off. But this fortunately didn't happen. So we were able to observe the first choice directly. As you saw, crowding was represented graphically. We had 5 levels from almost empty to packed. And I think what was most critical here was the ability to sit alone, as you'll see in the results. So sorry, just to go back, you can see that you can sit alone in the first 3 levels. In fact, the first 2 levels, and then you're not able to sit alone, but it's still not too crowded. And then it gets really crowded where we expected respondents to really feel unsafe. We had 3 waiting time levels, 3, 12, 25, 3 in-vehicle time levels, 10, 25, 40. We chose a larger range to actually observe trade-offs. So like I said, for infection rates, this is the value that the Dutch government estimates, but it did not at the time of the first study. So it did not estimate what is the proportion of population that is currently infected with COVID-19, but we felt that this was an ideal metric to provide some pandemic context to the respondents. Because if we gave them a number of positive cases, that would be influenced by a lot of things, such as the availability of testing, the willingness of people to get tested, whereas such an estimate was definite and objective. And so, although it was not available at the time from the government, we still use this. We just use a back of the envelope calculation, which is based on the daily reported positive cases. But even so, these are still absolute numbers. So what does it mean if 100 in 100,000 people are infectious? So it's difficult for a respondent or a traveler to understand these values. So to help respondents interpret these, what we linked it with the real world situations. So we said, okay, the proportion of people who are currently contagious is 0.1, and this is what is the situation currently. And then we said it was 0.5, and this was the situation in mid-April. Again, we just used a simple back of the envelope calculation to get these values. So overall, we were correct, as you'll see in the next slide. But we had 5 levels. So we had pre-restriction level. We had the level at the time of the survey, that's 0.1. The level at the peak, which we thought was mid-April. And then we had an extremely high level, which is 10%, which hopefully never happens, because yeah, that would be catastrophic. So like I said, we did get a bit lucky with our numbers. We were not too off. So their values for April 15 and May 20 were 0.34 and 0.08, so not too different from 0.5 and 0.1. Although they did estimate the peak to be not mid-April, but actually end of May. But we were about right, given that the respondents didn't have better information either. We used a random experimental design for those interested in the design of experiments. We just used a full factorial design, removed weakly dominated and symmetric choice situations. And then we said, okay, we'll take 4 subsets of 15 choices randomly and present each respondent with one of these subsets. So each respondent saw 15 choice situations. We did do a lot of multinomial models. In fact, we also did mixed logic just to test out what's going on. But eventually, we thought that the latent class choice modeling approach was elegant over here, because it would be able to explain. It would be able to segment the travelers into well, classes which we found were relevant for policy interpretation. So what this model does is that it explains heterogeneity in behavior through a discrete mixture of choice models and a class membership function. So a combination of these two, rather than a continuous mixture of choice models as you have rather than a continuous mixture as you have in mixed logic. Like I said, we segmented the travelers with this. So we found a 2-class latent class model to perform the best, to at least give us the best interpretation of what's going on. It's always a bit of an art than science at this point. And these are the utility equations we use. So as you can see, for the train alternatives, we had crowding as ordinal variables. So these were effect coded here. We had waiting time and infection, waiting time as continuous, and then we had crowding interacted with infection rate and in-vehicle time. You'll notice that there is no, we also included, so we included the in-vehicle times in the opt-out option. So if you have, because the in-vehicle times were the same across both options. So for the opt-out, we had an opt-out penalty. We also had continuous variable for in-vehicle time. So if the trip is 40 minutes, are you with both trains, if it's 40 minutes, are you more likely to opt out or not? And then we had effect coded variables for infection rate. I'll go directly to the results here. So in line with intuition, we did find higher crowding, a higher waiting time, and a higher infection rate reduced the probability to board a train. So people opted out or chose the other train. And in general, if these were higher, then people would just opt out. Surprisingly, the in-vehicle time that we included in the opt-out option did not have any effect. So it is possible that people are underestimating the importance of duration, which was quite surprising for us. In fact, that it was completely ignored. But I must say that these effects do happen, especially if you include these effects too. So you tend to miss out on context effects quite often in stated preference questionnaires. Somehow, I think respondents don't seem to pay attention to context effects as much as they pay to alternative attributes. But in this case, we did find significant effects of infection rates, but just not for in-vehicle times, even though both were context effects. A possible reason is that infection rates is just such a strong parameter here, given the context of the whole study. Whereas people might not have realized that in-vehicle time is actually talking about, so the more time you're in the train, it is increasing your exposure. So that the combination of it being a context effect and it being not such an obvious impact, not having such an obvious impact on your risk perception might have contributed to this finding. And finally, we found two almost equally sized classes. One we called COVID conscious. So we found nice names for them. They were alliterating. So COVID conscious and infection indifferent. But these names had a purpose behind them. So COVID conscious travelers were strongly driven by crowdedness, infection rates, and the expected number of infected persons on board. So expected number of infected persons on board is basically the number of persons on board multiplied by the prevalent infection rate. So the interaction effect we saw earlier. In contrast, we found that infection indifferent travelers are affected by these factors to a lesser degree and are also less likely to opt out on average. I'll go a bit quick because I see half the time is gone. So on average, we found that COVID conscious travelers were willing to wait a surprisingly high 8.75 minutes to reduce just one person on board. So that shows you the degree to which these people are risk averse, at least in this case of the pandemic. And we found sharp increase in willingness to wait when there's a possibility to sit alone. So like I mentioned before, when you're going from the first two levels to the third level, or conversely from the third level to the first two levels, there's this much higher willingness to wait. On average, the infection indifferent travelers were willing to wait only 1.04 minutes, and this is more in line with estimates we have from pre-pandemic studies, both stated and revealed studies. The graphs show the opt-out behavior. So what is the tendency to opt out given the infection rate and the tendency to for both the classes. So as you can see, there is a plateau at 2%. After 2%, people don't seem to be affected by the infection rate. This might make some sense because 2% is already quite extreme, and then of course 10% is an extreme value, which is highly unlikely to occur. So it might make some sense that this effect is plateauing here. That people are simply are not considering these extreme values. But what's also interesting is that there is a low elasticity of opt-out rates for higher crowding levels. So the different colored lines show the load factors or seat occupancies. And as you can see, the probability of not using train is quite high, and there is a low elasticity. So for once you are above 50%, it doesn't matter if you're 75 or 90. The probability of opting out is already quite high for the COVID conscious group. This is a bit this effect is a bit less in the infection indifferent group because they're already less likely to opt out. Since we use the LCCM model, the latent class choice model, we can also explain class membership through social demographic and mobility characteristics. And we also found some for the COVID-related measures that we had collected, we used a posterior analysis. I'll come to that next. This is something we find in a lot of risk aversion studies, that we find older and female respondents to be overrepresented in the risk averse group. That's also what we found here. So they were overrepresented in the COVID conscious travelers. But on the other hand, those who reported that they have used the train more often during COVID-19, during the restrictions related to COVID-19, they were more likely to be infection indifferent. And this makes sense that if they have experienced, the more you experience a particular risk, the less averse you're likely to be to it. So this is also something that's in line with intuition. What we were surprised by was that having a private mode was not related to the propensity of opting out. Again, this could be because travelers felt that they should not consider this factor when making a decision whether to take train 1, train 2, or opting out or opt out. But nevertheless, we expected to see some correlation, but that wasn't there. Finally, we did posterior analysis of the COVID-19 related factors. We only had small differences, but again, these were in line with intuition that COVID conscious travelers were more worried about the pandemic in general, were more worried about being hospitalized, were more worried about the close ones, about close ones who were vulnerable in particular. And surprisingly, they also reported themselves to be more rule following, and at the same time had a more negative opinion about the degree to which others followed these rules. So not only that they felt that they were doing everything right, but they felt that others were not doing anything right. But I think what was the most surprising was, but also on the other hand, I expected that face mask use did not follow this pattern. So both COVID conscious and infection in different travelers did not like using face masks, and this is, I think, something in line that's with the debate that's gone on in the Netherlands. They only mandated face masks in all places in December when the strongest lockdown was in place. Although face masks were mandated since June 2020 on public transport. In shops, in restaurants, they were not mandatory and until December 2020, and I think the rule was already removed by February 2020. So it seems that the Dutch really do not like using face masks, and this is again what we saw in the data. I'll stop here for any questions before we move on to the next one.
Okay, so as Sanmay said, there are you can ask questions perhaps in the usual way with the Q&A button at the bottom of the screen. You can type that in the box and I'll read them out loud to our presenter. You can also raise your hand using the little raise hand icon, and I'll unmute you and allow you to talk to Sanmay directly. I think just to kick this round of questions off, I was wondering how you went about dividing the respondents into the two classes that you produced, the COVID conscious and the infectious indifferent.
Right. So the latent class choice model is based on the concept of discrete of mixing discrete choice models. So discrete mixtures of choice models. So what we did was we tried a number of classes. So we tried 2 classes, 3 classes, 4 classes, just as you would with clustering. So you have 2, 3, 4 clusters, although this is a little different from clustering. And we found that although the model fit it kept improving, as it almost always does. But even when we included the penalty of having to estimate extra parameters, the interpretability of the two-class model was the best. And then we simply interpreted the two classes based on their properties to be COVID conscious and infection indifferent.
How did you assess the different characteristics of the classes, such as being more or less worried about the pandemic or more or less rule following? How did you, was it the same sort of method to assess those type of answers?
No, so for the rule following, and so for all of these qualitative measures, because these are all measured with Likert scale, we did not want to include them as a latent variable in the model directly. So what we did was we did a posterior analysis. So in latent class choice models, people are assigned to classes probabilistically. So we took these probabilities and then we simply multiplied them with the responses of each individual. So let's say an individual is 90% likely to be in the COVID conscious class and 10% likely to be in the infection indifferent class. And then he answers, oh, I'm very rule following. So I scored 5, for example. So you get 90. So you get a 4.5 score for the COVID conscious and a 0.5 score for the infection indifferent. Then we simply take the sum of all these scorings and take the average for each class. And that's how we get, okay, on average, this class as this rating.
Okay, I have another 2 questions. For Anush, I think Sanmay has answered the question we both came up with. You can ask another if I'm incorrect. Jani asked, since willingness to wait or sit on the train is sensitive to ridership up to a certain crowd level, up to a certain crowd level in the train, there might not be an option to consciously stay away from others. Do you observe any trade-off between being conscious of this fact and the affordability of other travel modes? So I think Jani elaborates, maybe a small percentage of people are willing to switch to modes, for example, shared ride. Okay, so this is a big question here.
Yeah,
I think you mentioned this a little bit, but the trade-off between affordability of the other travel modes, or the trade-off between like the kind of awareness of the distance to other riders.
Right. So we did study this. So we did the study in the closed environment of, okay, you have these 2 train options, but then we included the opt-out option. What we had planned to do was see if the tendency to opt out is somehow correlated with the other travel modes available to this person, right? So if you have cars, or if you have a bicycle, I mean, if you can make the trip that we are talking about. So if you remember in the situational context we had, you're traveling to work. So the question we had asked was, are there any other modes that you can use to make this trip? And then we wanted to see if there was a correlation. We did not find any such correlation. Yeah, we did not check so we hope this would have also included affordability, because if someone says this is available to them, they might use it. But yeah, we did not explicitly include euro cost. So no euros were included in this study.
Okay, so try to be conscious of time here. I think if anyone has any more questions about this section of the presentation, you can also feel free to ask those at the end.
Let me ask a quick question. So when in your data collection, what time period did you cover for collecting that for the survey of the travelers? Because I think what we were seeing was like a lot of essential workers that had to commute. They don't necessarily travel during the typical peak hours. So
right. No, this was an online panel.
Okay.
So we did not include, or do you mean if we included a travel time?
No. Like if you were selecting your samples for the survey, whether you're asking train travelers from a specific time of day, or I guess in this case, it was any.
No, we did not filter. We did not have any travel, specific commute or departure time stratifications. We only had them. We only had strata related to age, gender, and education. Perhaps education captures a bit of what you want to say, but not always, because you can have essential workers of all levels. Yeah.
Right, thanks.
Yeah.
Yeah, I think we can proceed to the next.
All right. So the next, everyone can still see my screen. Right? Yeah.
Yep.
So the next study is actually a master thesis student. Is by a master thesis student I supervise along with Eric Molan. So the student is Thijs van der Wiel, and so we are co-authoring. I'm co-authoring this paper with Eric Molan, Hans, and other. Yeah, so we saw a bunch of three critical and objective factors that contribute to the risk of COVID-19. But then we also have a lot of COVID-19 measures that have been implemented. So we have this whole hygiene theater, which some people are critical of, and are saying that this is just providing false sense of security. We have some people asking for masks, like in the Netherlands. Some people going the other way. Then we have even more evidence, or lack of evidence, that the public transport does not pose a risk of coronavirus outbreaks. So people are citing this lack of evidence, saying that, oh well, it's probably safe because nothing has happened yet. And then you have restrictions being eased. So like in the Netherlands, you also had them here where seat blocks were removed and full capacity was allowed to be utilized. So all of these factors, so which factors are in place, will also likely affect risk perception. So it's likely than just the three ones we studied. Three more will also affect the subjective perception. To accommodate this risk perception in travel decisions is a complex problem, and for such complex problems, particularly where abstract concepts such as risk perception and safety are present, decision makers are more likely to use perceptions of reality rather than individual objective measures separately. So they're more likely not to trade off each and every measure, but to gather all these measures, form a decision construct, and then use that decision construct to make a decision. So this is indeed better conceptualized by modeling risk perception as a latent variable that affects choice behavior than rather than what we just did. What we just did was fine because we had three variables, but like I said, there might be more. And then you, instead of trading off each variable, it's much more likely that that the decision makers are actually forming constructs and then making decisions based on that. So we employ the hierarchical information integration approach. That's a bit of a mouthful. I'm just going to call it HII from now on. So the basic assumption in HII is that decision problems are divided into subproblems. These subproblems are then evaluated to define decision constructs. And then all of these separate decision constructs are integrated into one overall judgment or preference. So conversely, to measure this behavior, we can also divide the problem into sub-experiments and then combine these sub-experiments via a bridging experiment. And then what the bridging experiment will do is that it will include all the decision constructs as attributes, and then it will measure their part-worth utilities by observing decisions or judgments. So in addition to being more in line with how decisions are made conceptually, this will also allow us to study a larger number of COVID-19 related factors without excessive cognitive burden, because we do not need to repeat a large number of factors for each choice situation. Rather, we just divide this into sub-experiments and then integrated into one bridging experiment. So this is how it looks, how the HII approach looks for us. So we have just one sub-experiment, which is for the COVID-19 risk perception, to measure the COVID-19 risk perception. As it says here, in this sub-experiment, we observe the risk perception. And the risk perception is based on what we were trying to include was 3 types of attributes. The first trip specific, which was onboard crowding and number of transfers. So onboard crowding will obviously affect risk perception. Number of transfers can affect risk perception because every time you board and alight, you get in close contact with a lot of other people at the doors, and every time you transfer to a new train, you're also exposed to new people. Then we had policy-based attributes, whether you have increased sanitization, mask mandates, and the lockdown status generally in the society. And finally, we had pandemic context attributes, which is similar to the previous study. We had infection rates, so the number of the proportion of people who are currently infectious, and of course, risk perception is also could be, I should say, dependent on a number of personal characteristics. And then in the second part of the experiment, which is the bridging experiment, we had a choice experiment, a route choice experiment specifically, where the risk perception we had just observed, it now acts like an attribute, and its values are varied by statistical design. In addition to the risk perception, we also had travel time and travel cost as attributes of the train alternatives, and we had personal characteristics. Again, these might also affect utility. So in this part, in the first sub experiment, which is the risk perception rating experiment, it's quite similar to the previous study. We had seat occupancy and ability to sit alone as attributes, number of transfers, increased sanitization, mask mandate. We had different lockdowns, as you had seen in the graph. I'll bring that up again, and different infection rates. Again, this time we did have values from the government, and we were also able to link them to different times in the past. So again, this graph is exactly what it shows. You see 3 lockdown levels, +1, no restrictions, and then you see different infection rates at different points in time. I'm going a bit quickly because I see I don't have a lot of time left. This is what the risk perception rating looked like. We asked them to rate from 1 to 5. And then we had the route choice experiment, which we divided into short trips and long trips, just to bring it closer to what people are familiar with. So short trips was anything less than 30, if your usual trip was less than 30 minutes, and long trips is if it's greater than 30 minutes. So what the travel cost and travel time looked like. For COVID-19 risk perception, we presented this as your infection risk rating. So just to tell respondents that this is the same risk rating that you would have given if this was shown to you, if this train alternative was shown to you in the previous experiment. And then we just varied it from low, medium, between low, medium, and high. So like I said, this was all varied by statistical design. This is what the route choice experiment looked like. We asked people to choose between train 1 and train 2. And similar to the previous experiment, we wanted to give them a chance to opt out. So we after they had chosen a train trip, we said, okay, would you like to select this one, or would you like to opt out? And then after the opt out, after the end of the route choice experiment, we also asked them, well, if you opted out, what would you do? Would you cancel your trip? Would you use another mode, or would you just do the activity at home? So if that was working or studying, would you do it at home? So you also had a kind of division in the opt-out options. We use a de-efficient design for the route choice model, and we use orthogonal design for the. I haven't included here, but an orthogonal design for the linear regression model. We got 400 valid responses, and like I said, conducted in the first week of December 2020, just before the strictest lockdown was implemented. Generally representative of Dutch train users, and again, similar social demographics and other characteristics were collected. We did this we modeled the risk perception with an ordinary linear regression model. Ideally, we should have chosen an ordinal regression model. I'm not going into details, but this was just to preserve model parsimony. And again, fortunately, not a lot of people chose the opt-out option, so we were able to select the first choice among trained alternatives. And we tried a number of multinomial and mixed logic models, but eventually went to the mixed logic model with normally distributed travel cost and risk perception parameters. In line again with the previous study and other studies in literature, we found high crowding and infection rates to increase risk perception. In fact, this had the highest impact on risk perception, and mask mandates and increased sanitization improved the perception of risk. We found that some degree of governmental intervention was appreciated. So while no lockdowns, no restrictions, people felt a bit unsafe and no restrictions. Some degree of, so if you had a moderate lockdown, this actually made people feel a little more safe. And you can see how the effect could go both ways. So if there is a lockdown, people might feel safe because they are of the impression that the government is managing things and will get it under control. Whereas if the lockdown is too strict, this might add to their worries or risk averse tendencies. And again, we found that, and this time we actually measured it explicitly in the linear regression model. So quantitatively, we found out that the vulnerability of family and friends had the highest effect, and it was almost twice as much as anxiety related to personal health. We did not see any social demographics that we had seen previously. Again, for the route choice model, the opt-out options that I discussed had no effect, so it did not matter whether you're canceling the trip or doing it from home. Similar to the previous study, we did find that the younger travelers and those who use the trains more frequently placed a lower weight. So they were overrepresented in the infection indifferent class, and here they placed a lower weight on risk perception. We found similar values of time, similar to pre-pandemic levels, so it was 9.36 euros per hour. Surprisingly, we did find a significantly higher value of risk in longer trips. So it's in fact 3 times, even more, almost 4 times that of shorter trips. One might think that the willingness to pay for this is simply because it's a longer trip. But we tested for this explicitly to see if exposure duration had an effect. That didn't. So exposure duration didn't have an effect, but it might just be that people at the back of their minds do keep the length of the trip in mind, just not within the experiment, just not within the range of values provided in the long and short term experiment. Yeah, so we found that there was a willingness to pay of just 1.6 euros to be able to sit alone, and just to compare it with the fare for the extra fare to ride in first class, where you can expect a lower crowding, you can expect wider seats and some other amenities. Is just for comparison, you need to pay 8 euros extra over and above your ticket price to sit in the first class for a trip of about 45 minutes, whereas for longer trips, people are just willing to pay about 1.6 euros to be able to sit alone. And as I mentioned previously, this is so longer trips, people are more risk averse and willing to pay higher. And then you have some, we're also able to calculate the willingness to pay for increased sanitization. I'm just going to rush through the conclusions I have here. So this is the last slide. We saw a clear divide in behavior, and this is also something at the time we saw anecdotally that we have risk averse and people who just don't seem to care about COVID-19. While there is cautiousness, there is also, on the other hand, unwillingness to travel. So there is likely it could be a sign of problems that even with low infection rates, if the crowding is high, people are just not willing to take the train, especially the 50% that we had in the COVID conscious group. Crowding and infection rates are the primary contributors. I think this is something we expected. And willingness to pay, and like I said, this might be a protest answer. It might actually be the case that willingness to pay is not as high as the options currently available, for example, paying for the first class. That's it. Was a bit rushed at the end, but I hope it was, we were still able to get through it.
Okay, so we already have so again, feel free to write your questions in the Q&A box or raise your hand. We have one question from Professor Ray Zimmerman. Have you accounted for this? Does the need for the trip influence perception? I guess you kind of covered this a little bit in elasticity, but the need for, so how does trip need influence it?
Right, so we did not find, of course, we did not measure how much you need this trip. We just had trip purpose. It was work, study, and others, errands, recreation, etc. So we did not find an effect of trip purpose on the route choice models. But also we did not find an effect of the opt-out option. So if people could do the activity from home, were they more likely to opt out? That was not the case. If people had to cancel the activity, were they less likely to opt out? Also not the case. Or at least that's, we did not find a significant effect for it. So we can't say it's the case.
How do you anticipate these results would change over time? So perhaps observation of pandemic fatigue or multiple waves, multiple lockdowns. How do you think this would influence the results?
Oh yes, most definitely. So the situation is very fluid, and it has been since the last 1.5 years. So you have infection waves going in and out. You have vaccination availability. Then you have people, you see vaccination rate increasing, but then you realize, okay, there's a proportion of people that are not going to get vaccinated. So all of these situations are quite fast changing, and then you have variants coming in and out. So I absolutely expect these values to change. I was in fact surprised to see still that there were the lines of consistency between these two studies and also other studies in literature. So there are some factors that seem to remain consistent over at least over the last year. But this could definitely change with the vaccines. So I haven't come across studies that have collected data after a wide availability of the vaccines.
Yeah, actually, I was curious if that was something that you were thinking of as like a next step in the future research, looking at the case with the vaccine penetration and whether or not how different operating policies by the transit agencies would change under those circumstances.
Yeah, so I don't have any research plans personally, but we will be supervising a student who's looking at working from home and going to the office, how these trends are changing with vaccination rates. But it would certainly be interesting to see how this affects people's perceptions. That okay, X proportion of people other than you are vaccinated or not. Yeah.
All right, so we're just about out of time. So I want to say thank you, Sanmay, for presenting your research today. Thank you for Professor Chow for helping to host and moderate. And thank you to all attendees for joining us. Please join us for the next C2 Smart webinar. Sign up for our newsletter if you're not already on it. Follow us on Twitter and on LinkedIn. And we hope to see you soon.
Thank you.
Thanks, Sanmay.
Thanks.
Take care.